Bismillah ar-Rahman ar-Rahim. Today we will continue the second part of inflammation and repair. أنا الدكتور معاذ رجوب إن شاء الله راح أعطيكم هاي المحاضرة inflammation and repair part 2 وراح أكمل إن شاء الله معكم نيوبليزيا بعد الدكتور محمد العرجاني. So last time you talked about chronic inflammation, types of chronic inflammation. And you started talking about repair and regeneration. One of the most important things in our body to regenerate our cells are the stem cells. Now, stem cells أو اللي هي بالعربي الخلايا الجذعية, they have certain features that discriminate them from other cells. They have self-renewal capacity, which means that they are stable in their number. They do not decrease or increase. They renew themselves. They have what's called asymmetric replication, which means that when the stem cell replicate into two cells, one of the cells will go and continue its journey through differentiation and maturation, and the other one will go back and become another stem cell to keep the population of the stem cells stable. Also, they have capacity to develop into multiple lineages. Those are what's called pluripotential stem cells, which means that they can develop into multiple types of cells and different parts of even the embryonic layers, which are the ectoderm, mesoderm, and endoderm. And they have an extensive proliferative potential, which means they can proliferate. They have unstoppable proliferation activity or capacity, and this is related to some features that they have. Now, stem cells have two main types: embryonic stem cells, which are pluripotent cells that can give rise to all types of tissues of the body, ectoderm, endoderm, and mesoderm. And we have the adult stem cells, which have restricted differentiation capacity. They are lineage specific. So we have stem cells in the GI tract that only produce GI cells. We have stem cells in the bone marrow. We call them hematopoietic stem cells. They only produce hematopoietic elements. We have some feature that we can do in the lab. They are called induced pluripotent stem cells. They are derived by introducing into mature cells genes that are characteristic of embryonic stem cells. So we have a mature cell, we introduce a genomic material that are characteristic or only seen in embryonic stem cells in order to change the characters of this cells into embryonic stem cells. They can acquire many characteristics of stem cells. Okay, so this is the process that we have been talking about. We have a patient cell that is adult and mature, and we have genes that are seen in embryonic stem cells. So we add those genes like OCT34, SOX2, CMYC, KLF4, and NANOG to those cells. And once those cells take those genes, they will have some features of the stem cells. They have patient-specific induced pluripotent stem cells, and thus they can differentiate by certain induction factors into different types of cells. So what is the impact of embryonic stem cells on medicine? First, we have a study of specific cell signaling and differentiation steps. We have, when we have a proper understanding of the stem cell process of differentiation, we will have more information about cell signaling and what are the mediators and the factors that cause those stem cells to proliferate and to differentiate into different types of cell lineages. Also, they can produce knockout mice in the labs. This is something complicated. Also, they have the possibility of generation of a specific cell types to regenerate damaged tissue, which is called regenerative medicine. You know that we have quiescent cells and we have stable cells. Stable cells that they do not divide, like the cardiac muscle and the neurons. And once the patient have loss in those types of cells, they will never regenerate. So in regenerative medicine, they are trying to regenerate those cells by production of induced pluripotent stem cells, make them differentiate into neurons or into cardiac muscle cells and implant them into the patient's damaged area in order to regenerate those damaged cells. So where do we find the stem cells in our body? In the skin, usually the stem cells are found near the hair follicles in the bulge of the hair follicle. They are called epidermal stem cells. In the intestine, they are found in the base of the crypts. Here we have the crypt of the intestine, which is like a glandular structure of the intestine. Here are the stem cells that proliferate and regenerate those epithelial cells. Also, we have in the liver, they are near the herring canal. Here we have the stem cells of the hepatocytes. In the cornea, they are at the base or in the basal layer of the corneal epithelium. They have stem cells and they regenerate when we have damage into the cornea. So also we have in the bone marrow, we have the hematopoietic stem cells, which are responsible for a production of the blood constituents, including RBCs, white BCs, and platelets. In the liver, in the herring canal, as we said. In the skeletal muscle, we have the satellite cells, which are present near the skeletal muscle fibers around the blood vessels. And once you have damage in the skeletal muscle, sometimes those satellite cells can proliferate and produce new skeletal muscle cells. In the intestine, as we said, in the base of the crypts, and in the skin, it is at the hair follicle bulge. An important topic to talk about are the growth factors. Now, growth factors, most of them, they are polypeptide growth factors. They are composed of proteins. Now, the growth factors are chemical mediators that affect cell growth by binding to specific receptors on the cell surface or intracellularly. So they are certain molecules, polypeptides, that bind to certain receptors, whether on the cell surface or intracellularly, and this binding results in exertion of certain functions of different types of cells. They are the most important mediators affecting cell growth. They are usually present in the serum, in the blood, or produced locally, only locally. They exert their function locally. They have pleiotropic effects like proliferation, cell migration, differentiation, or tissue remodeling. One growth factor can exert multiple functions, and also multiple growth factors can produce the same function. They regulate the growth of cells by controlling expression of genes that regulate cell proliferation, which are called proto-oncogenes. And proto-oncogenes, they have a very a tremendous importance in neoplasia and cancer production. So those growth factors are important in regulation of the function of genes that induce cell proliferation, which are the proto-oncogenes. There are a lot of growth factors. Many of them, we will talk about them here, and you need to remember the growth factors and their main functions. So the first growth factor is called epidermal growth factor and transforming growth factor or transformation growth factor alpha. Those factors or growth factors, they bind to a receptor called ERB-B1, and they exert the function of mitogenic for epithelial cells and fibroblasts, and also they induce migration of epithelial cells into their usual sites. Platelet-derived growth factor. Now, the function of platelet-derived growth factor is migration and the proliferation of fibroblasts, smooth muscle cells, monocytes, and it also has a chemotactic ability. You all know about what do you mean by chemotaxis. Chemotaxis is recruitment of inflammatory cells to the site of injury and inducing inflammation. So fibroblasts, smooth muscle cells, and monocytes, those are cells that are important in repair, as we will see in the next slides. Other growth factors include fibroblast growth factor, or factors, because there are a lot of them. They also induce mitosis of fibroblasts, epithelial cells. They also are important in angiogenesis, which means production of new blood vessels. Chemotactic for fibroblasts. They recruit the fibroblasts into the site of injury. And they are very important in wound healing, because wound healing include fibroblast function. Vascular endothelial growth factor. From its name, vascular and endothelial, it is important in angiogenesis, and also they can increase vascular permeability. And it is also a pro-inflammatory growth factor. We have the hepatocyte growth factor or scatter factor. It is mitogenic. They induce mitosis of most epithelial cells and also hepatocytes, which are usually not, as you know, they are stable cells. They need to be induced in order to proliferate. Also, it promotes scattering and migration of cells into their site and their site of function. One of the most important growth factors, and you will hear it a lot during the pathology courses, is transforming growth factor beta. Transforming growth factor beta binds to two receptors, type 1 and type 2, with serine threonine kinase activity. We will talk about that later. Those receptors will phosphorylate cytoplasmic transcription factors, which are called SMADs. Those SMADs will enter the nucleus and associate with other DNA binding proteins. They will activate or inhibit certain gene transcription. They will activate some genes and they will inhibit other genes. Now, the main feature or what makes this growth factor different because it is inhibitor to most epithelial cells and leukocytes. So it is an anti-inflammatory growth factor. Anti-inflammatory growth factor. It increases expression of cell cycle inhibitors and prevent the proliferation of cells like the CYP and INK4-ARF, which are anti-mitogenic, let's say. They stimulate proliferation of fibroblasts and smooth muscles, which are important in repair, healing. So they are not inducing inflammation. Stimulate fibrosis, like they induce fibroblasts, and they also cause chemotaxis and the production of extracellular matrix, which we will talk about later. They decrease the protease activity and increase the protease inhibitors activity, which means we will not have destruction of the tissue. That's why they cause fibrosis. So they have a strong anti-inflammatory effect. You need to remember this, this growth factor, very important. So this slide, I believe you have seen it a lot. It's the patterns of intercellular signaling. How do the cells interact with each other? Now we have three main types of signaling. Autocrine. Auto from its name means the cell produce certain factors, whether growth factors or certain hormones, and those will bind to the receptor on the same cell. That's why it's called autocrine. We have paracrine. Paracrine, which means the secretory cell will produce this growth factor and it will exert its function on the adjacent target cells. Paracrine, local effect. And we have the endocrine signaling, which most hormones in our body work in this pattern, in this type, by production of the hormone by the secretory cell into the blood, and it will travel into the blood into the target cells, which might be distant or might be nearby, and this is called endocrine signaling pattern. Now, what are the receptors that the growth factors exert their function through? We have receptors with intrinsic tyrosine kinase activity, which means the tyrosine kinase activity is built in within the receptor itself. We have receptors that lack this intrinsic tyrosine kinase activity. They recruit other kinases to do the phosphorylation. We have the 7 transmembrane G protein coupled receptors. And we have the steroid hormone receptors, which are usually present intracellularly, and they bind to the hormone and enter the nucleus. So those are the types. This is the receptors with intrinsic tyrosine kinase activity. They usually have kinases associated with the receptor itself, and they exert their function through different pathways, include the PI3 kinase pathway or the MAP kinase pathway, and those will have phosphorylation of certain factors like the RAS or the RAF, also the AKT, and those will go into the nucleus and cause transcription of certain factors. And we have also the IP3 pathway, which is exert their function by increased calcium intracellularly and have multiple effects. We have, this is the 7 transmembrane G protein coupled receptor, and those usually exert their function by the cyclic AMP pathway, and this will exert multiple effects. And we have those which are receptor without intrinsic tyrosine kinase activity. This will recruit kinase like the JAK and those JAK-STAT pathway. Through the STATs also, they will induce transcription factor activation or inhibition based on the function of the growth factor, the receptor. So let's sum up the points that we have talked about. So growth factors, receptors, and signal transduction polypeptide growth factors act in autocrine, paracrine, or endocrine manner. And we discussed the difference between those types. Growth factors are produced transiently in response to an external stimulus and act by binding to cellular receptors. Different classes of growth factor receptors include receptors with intrinsic tyrosine kinase activity, G protein coupled receptors, and receptors without intrinsic tyrosine kinase activity. Growth factors such as epidermal growth factor and hepatocyte growth factor usually bind to receptors with intrinsic tyrosine kinase activity, triggering a cascade of phosphorylation events through the MAP kinases, which culminate in transcription factor activation and DNA replication, which will induce cell proliferation. G protein coupled receptors produce multiple effects via cyclic AMP and calcium pathway. Chemokines, which are certain chemical materials produced by certain types of cells, they utilize those types of receptors. Cytokines generally bind to receptors without a kinase activity. Such receptors interact with cytoplasmic transcription factors and move into the nucleus. So most growth factors have multiple effects, such as cell migration, differentiation, stimulation of angiogenesis and fibrogenesis, in addition to cell proliferation. And we talked about different growth factors and their different functions. Now, let's shift to another topic, which is the extracellular matrix. Now, you all know that extracellular matrix is a major component of all tissues. They usually provide the provides the backbone and support. It regulates growth, movement, and differentiation of cells. So it's like the background that the tissue are present within. We have the basement membrane, and basement membrane, as you all know, is composed of type 4 collagen, adhesive glycoproteins, and laminin. And you will see this in the next slide. We have the interstitial matrix. Interstitial matrix means the material that are present within, in between the cells, in between the cells of the tissue. We have fibrillar and non-fibrillar collagens. We have elastin. We have proteoglycans and fibronectin. And we will talk about each of them. So this is the basement membrane. Here it is. So we have the basement membrane. It's composed of type 4 collagen and laminin and proteoglycans. Here are the proteoglycans, and here's the type 4 collagen, and here's the laminin. They are all connected together. And here we have the interstitial matrix, which we said, as we said, it's in between the cells. Now, here is the proteins or the material that is present within the interstitial matrix. We have collagens, fibrillar and non-fibrillar, elastin, which is responsible for elasticity, proteoglycans, and hyaluronone, which are all major components of extracellular matrix. Now, the collagen is the most common protein in animals. All animals, they have collagen, and we have many different types of collagen. Usually, it can be fibrillar and non-fibrillar, and this depends on the type and the components of the collagen itself. Some of them they are fibrillar and tough, and some of them are not non-fibrillar. Hydroxylation, which is mediated by vitamin C, provides strength. Fibrillar collagen from most of connective tissue in wounds and scars. Non-fibrillar, which is type 4 collagen, it is the major component of basement. So non-fibrillar collagen, which is type 4, is the major component of basement membrane. Another component of the extracellular matrix is elastin. Elastin usually provides elasticity and surrounded by a mesh-like network of fibrillin, which support elastin deposition. So fibrillin and elastin, they usually come together, and defective fibrillin leads to Marfan syndrome. Marfan syndrome is a syndrome that have the patient, they have extensive elasticity in their joints and they have problems in heart valves. It is not components of extracellular matrix part 2. We have the proteoglycans, which form highly hydrated gel-like material, protein core, and many attached long polysaccharides. They are called the glycose aminoglycans. Glycose aminoglycans, which means we have a core of protein and attached polysaccharides to it. Act as a reservoir of basic fibroblastic growth factor, and they are integral cell membrane proteins like the syndican. They are present within the membrane. We have adhesive glycoproteins like the fibronectin and the laminin. Domains of fibronectin, they have domains that bind to collagen, elastin, and the proteoglycans. So it's like a glue that hold the different types of the different parts of the extracellular matrix together. Also, they bind to integrins via RGD, which is arginine, glycine, aspartic acid domains. Those are the structure of the proteoglycans. We have heparan sulfate, which is this molecule. We have a polypeptide core and attached chains of polysaccharides. Here is the syndican, which is part of the membrane. And as we said, it's a reservoir for the basic fibroblastic growth factor. So it's attached to it, and once it's needed, they will be induced to produce this fibroblastic growth factor and will attach to its receptor. Fibronectin, here it is. As we said, it has multiple domains. Domains that bind to collagen, domains that bind to fibrin, and domains that bind to heparan sulfate. And they have this RGD, which is binding to integrin, part of the cell membrane. This is the laminin protein. And as we said, laminin protein is part of the basement membrane. It has a domain that binds to type 4 collagen, and it has a domain to bind to the cell, and it has a domain that binds to the heparan sulfate or the proteoglycan binding site, which is also part of the basement membrane. So let's move to another topic, which is repair by regeneration. Regeneration means replacing the injured tissue by the same type of original tissue cells. This usually happens in cells that are able of dividing and proliferation in labile and stable cells. While in permanent cells, as we will talk later, usually those cells, they do not proliferate and they do not regenerate. So once we have damage in the stable cells, the healing will be by fibrosis, not by regeneration. Fibrosis in cases of, let's say, cardiac muscle, but in the brain or the neurons, it is called the gliosis. Now, the process of regeneration involves two tissue components, the cellular component and the acellular or the extracellular matrix component. So we have cellular proliferation, and this is regulated by growth factors and the growth inhibitors. We have the extracellular matrix and cell matrix interaction, the interaction between the matrix, the extracellular matrix itself, and the cells, which is part of the regeneration process. Now, in order to have proper regeneration, we have to have intact basement membrane. And this basement membrane will direct the epithelial cell polarity, and it is essential for its orderly regeneration, because the basement membrane is like the map or the guide for the epithelial cell in order to have the proper regeneration. We have another type of repair, which is repair by connective tissue, which results from severe injury with damage to parenchymal cells, and stroma precludes parenchymal regeneration. When we have severe damage like ulceration that result in damage of the stem cells and damage of the basement membrane, this will result in repair by connective tissue formation, not by repair and regeneration with the same type of tissue. And repair occurs by connective tissue. Components of the connective tissue repair, we have new vascularization, which is angiogenesis, which is production of new blood vessels, proliferation of fibroblasts, and deposition of extracellular matrix. Then we will have remodeling and, let's say, fining of those three processes, and which will result in repair by connective tissue deposition, like fibrosis, as we said earlier. So this is the repair by connective tissue. We have This is the normal tissue. We have an area of injury, and this injury is severe that it cannot be repaired by regeneration. So you will have inflammation and the new vascularization, formation of what's called granulation tissue. This granulation tissue here, and we will have then fibrosis and lay down of extracellular matrix, which is result in scar formation. Scar here is the replacement of this tissue, which is normal at the area of injury, by fibrosis and scar tissue. This is the histological appearance of a granulation tissue. It's mainly composed of fibroblasts and a lot of capillary-sized and blood vessels. And this is the, let's say, transition tissue that is present at the area of injury, after the injury, until the proper repair by connective tissue happens, and lay down of extracellular matrix happens at the area of the injury. So the components of connective tissue repair, first one is angiogenesis. Angiogenesis, it can happen by two pathways, either from endothelial precursor cells, EPCs, or from pre-existing vessels. And this process of angiogenesis, as always, it needs growth factors to stimulate this process. One of the most important growth factors in angiogenesis is vascular endothelial growth factor. And this factor exerts different functions of endothelial cells. They increase migration, it increases migration, increase proliferation, increase differentiation, and also increase permeability. For stabilization of those newly formed vessels, in order for them not to be damaged or ruptured, we need also other proteins or other factors like angiopoietin 1 and 2, platelet-derived growth factor, and transforming growth factor beta. All those factors, they stabilize the newly formed blood vessel, while vascular endothelial growth factor, it stimulates the production of those new blood vessels. So angiogenesis from endothelial precursor cells, which is the first pathway. We have a cell that is called hemangioblast, and hemangioblast is a hematopoietic stem cell, and angioblast, their other name is endothelial precursor cells. Those endothelial precursor cells are stored in the bone marrow, and they express the markers of hematopoietic stem cells and of endothelial cells. Those cells are recruited by certain growth factors like the VEGF and the other factors. So they play a role in a new vascularization, which is production of new blood vessels, replacement of endothelial cells in case of damage, and also they have a role in re-endothelialization of vascular implants. Sometimes in patients we can use vascular implants in cases of severe atherosclerosis. Those cells, they are responsible for re-endothelialization of those vascular implants. Or even if you use, let's say, a vein or a part of other vessel to replace the damaged vessel. So this is the process of angiogenesis by EPCs. They are in the bone marrow. Then they have homing by, as we said, vascular endothelial growth factor or other factors. They will go from the bone marrow into the blood and then go into the area that they are needed to form the new blood vessels. So the other type of angiogenesis, or the other pathway, is angiogenesis from pre-existing vessels. So we have a parent vessel that sends out capillary sprouts to produce new blood vessels. Sprouting, it will start to produce, let's say, branches. This is sprouting. So the steps involved in the process of sprouting: degeneration of the parent blood vessel basement membrane. So we have to degenerate the basement membrane of the parent vessel in order for the endothelial cells to migrate and form like a primer, or let's say a tube of the new blood vessel. Then those endothelial cells will migrate and proliferate and form this new blood vessel. Then we have maturation of endothelial cells and organization into this tube. And the factors that involved in this process is the basic fibroblastic growth factor and also vascular endothelial growth factor, VEGF. Here is the process. So step number 1 is degeneration of the basement membrane, then migration of the endothelial cells and proliferation of them under the effect of growth factors. Then we will have maturation of those endothelial cells, Then we will have smooth muscle cells or pericytes that will continue the process of angiogenesis by stabilizing the blood vessel and forming the usual structure of the blood vessel, which is the other layers of the blood vessel. Increased permeability through gaps and transcytosis in between the endothelial cells. So this is the process of sprouting, production of network, and then this network of blood vessels will mature under the influence of the growth factors. So we have two main types of healing. The first type is healing by first intention, and this is the healing by first intention, and it's usually result from focal disruption of basement membrane and loss of only a few epithelial cells, like a surgical incision. When we do an operation, we open the skin and we have only focal disruption of basement membrane. So here we have the process of healing by first intention, and it will result in minimal scarring. And we have the healing by second intention. And healing by second intention results from usually a larger injury, abscess, infarction, and this will result in much larger scar, and then it will have contraction. Here is the healing by second intention. So here we have the scar and the clot formation, then we have inflammation, macrophages, fibroblasts, and then fibrous union of the tissue with reepithelialization. Here we have scar, large scar with a contraction. So wound healing steps starting by fibrin clot formation, which will fill the gap in between the two parts of the damaged tissue. Then we will have induction of acute inflammatory response by the initial injury. The first cells that will be at the site of the injury are the neutrophils within the first 24 hours. Then the monocytes will arrive by the third day. Then we will have regeneration of the parenchymal cells and migration and the proliferation of parenchymal and connective tissue cells and the granulation tissue formation. Then we will have synthesis of extracellular matrix protein. After that, we will have like formation of cells and extracellular matrix. Then we need remodeling of the parenchymal elements to restore the tissue function and provide proper shape in order the tissue to function properly. And then we will have remodeling of connective tissue to achieve wound strength and add more collagen and fibrous tissue in order to have strong reunion of the tissue. So fibrosis, one of the major components of healing. It's firstly we have immigration and the proliferation of fibroblasts, and we have multiple growth factors that can exert this function, include platelet-derived growth factors, fibroblast growth factor, epidermal growth factor, and transforming growth factor beta or transformation growth factor beta. We have also deposition of extracellular matrix, and also those factors are involved, and also some cytokines like interleukin-1 and the tumor necrosis factor. The process of scar remodeling is it's important in order to restore the function of the tissue. So we have a proliferation of cells and we have deposition of extracellular matrix, but this process in the first part of healing, it will be, let's say, random, and they need more organization by the process of scar remodeling. So it's a shift and change of the composition of extracellular matrix of the scar as a result of synthesis and degradation. So at parts where we need more synthesis, they will synthesize more extracellular matrix. And at the sites where we have, where we need degeneration or destruction of the extracellular matrix, this will result in degeneration of that part. So the metalloproteinases are the enzymes that are responsible for this process. Enzymes produced by many cells and capable of degrading different extracellular matrix constituents, like interstitial collagenases, gelatinases, and stromylysins. And all those enzymes, they degrade the parts of the extracellular matrix. Those metalloproteinases are activated proteases by the like plasmin. Also, they are inactivated by tissue inhibitors of metalloproteinases, which are called TIMP, and also steroids. So the steroids and the TIMP, they usually decrease the function of those metalloproteinases. Those are the phases of wound healing. As we said, firstly, we will have inflammation starting by neutrophils, then by monocytes. Then we will have a granulation tissue formation. And the granulation tissue, as we said, is a vascularized fibrous tissue. And then we will have wound contraction and lay down of more extracellular matrix and fibrosis. And this here we have the collagen accumulation and remodeling in order to achieve the proper strength and function of the area of damage. So in the terms of wound strength, now the sutured wounds have 70% of the strength of unwounded skin. And after the sutures are removed at 1 week, wound strength is only 10% of unwounded skin. So that's why you ask the patient to have, let's say, less movement and to stay at bed after that for, let's say, a couple of weeks until the wound strength become more in order to withstand any pressure or damage. By 3 to 4 months after the wound strength is about 80% of the unwounded skin. We have many factors that can affect the healing of wound. It can be systemic and it can be local. Now, the systemic factors include nutritional, systemic diseases, and other factors. The nutritional, when we have protein deficiency, this will result in delayed healing. Vitamin C deficiency, which as we said is important for collagen synthesis and structure. So this will also affect the healing. Zinc deficiency, which is important for metalloproteinases and remodeling of the scar. Systemic diseases like diabetes, arteriosclerosis, renal failure, and also infections, which are systemic. All those can hinder the process of healing. Corticosteroid treatment, which can also affect metalloproteinases, as we said earlier. Age of the patient, as the patient becomes older or as the age increases, the possibility or the healing will become less possible, and also the immune status. If the patient is immunodeficient or has a problem in his immunity, this also will result in delayed healing. Other factors that also can affect healing are local factors like infection at site of the let's say of the wound, poor blood supply due to atherosclerosis in the area itself or due to some other problem, type of tissue, if the tissue is not well vascularized or if the tissue does not have a strong capacity of healing, presence of foreign body material which will hinder the process of healing, ionizing radiation, and mechanical factors, including excessive movement. If the patient moves a lot or exert pressure on the wound, this will result in delayed healing. Hematoma, collection of blood, also will result in problem in healing. And apposition, if the skin, two parts of the wound are not apposed in a proper manner, this will result in delayed healing. So what are the problems that can be associated with the repair process? First of all, we have aberration of a growth may occur, like exuberant granulation. There will be excessive amount of granulation tissue during the wound healing. So if you look at the wound, you will have like a granulation tissue is coming out of the wound. And this is called exuberant granulation. This is usually does not have bad consequences. It is something temporary that can go away after healing of the problem. We have keloid. Keloid means excessive collagen accumulation during wound healing resulting in raised tumorous scar. Now, keloid, that there will be very, let's say, excessive collagen deposition, that there will be like large scar and that is different from the nearby areas. It will be tumorous, like there is a tumor or a mass at the site of the wound. We have excessive fibrosis. This will result from chronic inflammatory diseases like cirrhosis, pulmonary fibrosis, and rheumatoid arthritis. This will result in fibrosis that is unneeded, that is excessive than the needed fibrosis. Tissue damage also, this results from collagen destruction by collagenesis in rheumatoid arthritis and formation of nodules and other rheumatological conditions. This is the appearance of keloid. Look how there was this supposed to be a scar, but it's continue growth and fibrosis and deposition of collagen until it become like a tumor affecting the area of the wound. And histologically, as you can notice, there will be thick roopy collagen at the area of the keloid, which is a pathological process that result from improper or excessive collagen deposition and lay down at the area of the wound. Thank you very much. Any question, you can just message me on the e-learning or on the email, and I will be happy to answer any question for you.